talk في السيشن Precision Medicine in Epilepsy by Professor Levin Laga. Professor Levin Laga is head of Pediatric Neurology Department in Leuven, Belgium. وإن شاء الله بإذن الله هو فيرتشوال فهنسمع المحاضرة.
These are my disclosures. So if we think about treatment of epilepsy, you can define actually nowadays a couple of different steps. And if we start below, you have actually what we used to know for years. It's like by chance that you find a drug that is effective for an epilepsy syndrome. For instance, stiripentol effective for Dravet syndrome, or valproate for juvenile myoclonic epilepsy. But there was no link between the etiology of the epilepsy or the pathophysiology of the epilepsy and the working mechanism of the drug. So when we go higher, like step 2, 3, and 4, you see that nowadays more and more we do find drugs that are really linked to the etiology of the epilepsy. For instance, and I will give you that example, if you look at the tuberous sclerosis complex, we understand the mTOR pathway, and it's reasonable and logic that we would use an mTOR inhibitor like everolimus to treat epilepsy. Now, steps 4 and 5, and I will talk about this, is the new genetic treatments, and actually that's really what will happen in the future for many of the childhood epilepsy syndromes, that we will be able to change actually the etiology, to change the gene expression, or actually the gene itself, to treat these children. Now, let's start with network treatments. Network treatments means that you're trying to influence with your treatments the full network, which is very rare and difficult to do. But there's one nice example, namely Lennox-Gastaut syndrome. Now, in 1966, Gastaut already published that the Lennox-Gastaut syndrome, or his syndrome, is actually an endpoint of a mode of reaction of a child's brain to any etiology. Nowadays, we understand that different etiologies can lead to Lennox-Gastaut. So Lennox-Gastaut is a secondary network disease. And on this slide, you see, for instance, like that polymicrogyria, or even a tumor, or band heterotopia, or focal cortical dysplasia, at some point can develop into a Lennox-Gastaut syndrome. So it's like an endpoint, a secondary network disease. And this is very nicely shown in this picture. On the left, you see actually different etiologies for the epilepsy, and then the network is changing, and then at the end, you see that all these patients have the typical biomarkers of Lennox-Gastaut syndrome, like slow spike wave and tonic seizures. Now, what is happening? Nowadays is that people looked at all the imaging studies in Lennox-Gastaut, and they tried to identify these areas that are really crucial to understand the pathophysiology of Lennox-Gastaut. And apparently, the prefrontal cortex in red here is most important region if you consider Lennox-Gastaut syndrome. In the next step, they looked at the interaction of that region with all the other areas in the brain, and they found a very close correlation or association or network with the thalamus, with the anterior nucleus of the thalamus. So now there are trials ongoing to stimulate or to influence by electric stimulation, by neuromodulation, this network in Lennox-Gastaut, and they are not only stimulating the thalamus as we used to know from previous studies, but at the same time also this very crucial prefrontal area. So in a way, this is, I don't see any results yet, but this will, or this shows what is possible. With neuromodulation, we can actually interfere with this end stage, with this network. Now, next level is pathway changes or trying to influence the pathway in epilepsy. And I will give you several examples. The most important one and the most or the best known is actually indeed tuberous sclerosis complex with mTOR inhibitors. Now, we all understand what is happening in tuberous sclerosis complex. There is a mutation in one of these TSC genes, and therefore the inhibition is lost, and you give this tendency to develop tumors and also epilepsy and also autism and behavioral problems. So by giving mTOR inhibitors, trying to stop the inhibition or the loss of inhibition, we are trying to treat this disease. And actually for the tumors, as you can see in the middle panel, for the tumors, if you give mTOR inhibitors, these periventricular tumors actually diminish with the use of mTOR inhibitors. But also for epilepsy, and on the right you see the very first publication on the use of everolimus to try to treat TSC children with epilepsy with everolimus, and you see that there's a clear effect. So that has led to this older publication on everolimus in tuberous sclerosis complex. And you can see with me that if you look at median seizure frequency reduction or seizure-free days, that there is a clear difference between the placebo response and the two arms of the trial. So actually, with everolimus, because we understand this pathway, with everolimus we are decreasing the seizure frequency in most of these children with tuberous sclerosis complex. Now you can see with me that the decrease is only 50%, and actually you could call this a bit of a disappointing result, because it's only 50%. You would expect that if you do such a big influence on pathophysiology that you see better results. But the point here is that this trial was done in children above the age of 2 years, so I think this is too late. If you really want to influence this pathway in tuberous sclerosis, I think you have to go much earlier with these treatments, and this probably will give much better results. The next pathway that I want to discuss with you is something I was involved with in very much, because we developed fenfluramine here in our university, and you know that fenfluramine now is in most countries available for Dravet syndrome and also for other epilepsies. The story is quite interesting because fenfluramine was used already so many years ago in 1986 for very difficult epilepsies, and Joy Cardi published this paper on 3 adolescents with photosensitive and compulsive epilepsy, I would say, like the 2 last ones, patient number 2 and patient number 3, they would have absences after compulsive eye closure. But these seizures, very rare seizures actually, were actually completely gone with the use of fenfluramine. Now fenfluramine is a serotonin drug, and because Dravet syndrome photosensitivity is also a characteristic of Dravet syndrome, we tried fenfluramine in Dravet syndrome, and that's how we found out that this drug is actually very effective in Dravet syndrome. There are many studies on this, and this is not the point of this presentation, but you can see with me, for instance, in this post-marketing study from my Italian friends, 3 months, 6 months or 12 months after the start of fenfluramine, you see that also for the younger children and the older children, you see that the seizure frequency goes down by more than 50, 60 or 70%. The interesting point is we really wanted to understand why fenfluramine would work. We knew that it had something to do with serotonin. So in the lab, in animal models, we tried to find out what was exactly the working mechanism of fenfluramine. And no surprises, we did find that fenfluramine has a major effect on some of the serotonin receptors, and especially, and that's important for the next slide, especially for serotonin receptor 2A and 2C. So if you influence with fenfluramine in these 2 receptors, you will have your effect. And on the right side, you see a very simplistic scheme of what is happening in Dravet syndrome. Normally, you have the pyramidal cell that is excitatory, but this is inhibited by this parvalbumin cell, GABA interneuron in red, and usually there's a nice equilibrium between excitation and inhibition. Now, in the sodium channels are mostly expressed on these kappa interneurons, these red interneurons. And the sodium channels are deficient in Dravet syndrome. So, because you have not enough inhibition, you have excitation, more and more excitation of pyramidal cells, and you have disease. So now with giving fenfluramine, the receptors for the serotonin are also on that kappa interneuron. So if you give fenfluramine, you will actually try to reduce this deficiency and increase the inhibition again, so that actually you're treating the epilepsy in these patients. So understanding the pathway of this disease also gives you an explanation why fenfluramine might work. And very importantly, people had understood this because, as I told you, 2A and 2C receptors are very important. And now there's a drug in test phase now in randomized controlled trials, bexicaserin, which is actually very selective, a super agonist of the HT2C receptor. So that means that here they selected one drug, one molecule, bexicaserin, and probably this will be a very nice drug also to treat epilepsy. They are focusing on one of these serotonin receptors. So understanding the pathway of serotonin gives rise to new medication. Now, the major part of precision medicine is at this level, at the protein level or the small molecules. And I think it all started like many years ago with this very simple clinical study. These were neonates and young children with KCNQ2 encephalopathy. You know that with KCNQ2 you can have a benign epilepsy, but you can also have a very bad epilepsy, what we are calling now KCNQ2 encephalopathy. And these children had like generalized seizures, but it was found out that in this study that with sodium channel blockers like carbamazepine and phenytoin, the epilepsy was treated very, very well. So now this has a huge impact in many neonatal epilepsy centers, because sodium channel blockers are now high on the list in the treatment guidelines for neonatal epilepsy. And this was also proved in a larger study. So you have the two groups, the benign group with KCNQ2 and the early onset epileptic encephalopathy. And you see with me the different treatments. White is effective treatment. So for instance, in the benign group, if you look at the sodium channel blockers, indeed 90% or even 95% of these children are very well treated with sodium channel blockers. Also in the early onset epileptic encephalopathy, you see that sodium channels are doing the best. Although the picture is completely different, there is much more black. That means that it's much more difficult, of course, to treat these epileptic encephalopathies. But that's a nice example, a very starting point for precision medicine. We have the etiology, KCNQ2, and we know that we have to give sodium channel blockers. Now the story becomes a bit more complicated, but this is becoming a clinical reality. It's not only enough to understand that the patient has a mutation in a gene, you also have to understand the functional repercussion. And so this is also a review study on sodium channel 2A epilepsies. And if you have a mutation in sodium channel 2A, you can have a diverse phenotype. You can have very bad epilepsy, like in red, West syndrome, Lennox-Gastaut syndrome, myoclonic static epilepsy, or you can have benign epilepsy, or you can even have autism without epilepsy. So why is it that mutations in this gene can cause such a diversity? And that's what you're seeing in actually all the newly described genetic epilepsies. Now, you have to know the functional repercussions. So for instance, in this case, in SCN2A, if you have a gain of function because of the mutation, usually your epilepsy will start very early. And then the epilepsy will be, like in KCNQ2, a benign epilepsy or actually a very bad epilepsy. But because it's a gain of function, it's a sodium channel, so too much sodium channel in a way. The way to treat this epilepsy is, of course, to give sodium channel blockers, because you will reduce the gain of function. Now, if you have a loss of function in that gene, you will not have an early onset but a later onset of the epilepsy with the loss of function. Usually you have a milder epilepsy, but here you have to be very careful not to give sodium channel blockers, otherwise the epilepsy will get worse. So apart from knowing the gene mutation, you have to also know the functional repercussion. And I give you another example. This is a very recent example, and it's always the same story. So this is a new mutation in a potassium channel, KCNA3. And again, this mutation causes a very severe epilepsy, the developmental and epileptic encephalopathy. Very nicely described, not hundreds of patients, but a very nice set of patients with this KCNA3 mutation. Now, these children actually present with different problems, but also very severe problems. Like the large majority, as you can see, had delayed speech development. Many of them have epilepsy, like 2/3 have epilepsy. One out of 4 had ataxia. So you can see the phenotype, and it's always the same story. There's diversity of the phenotypes. Now, again, not only the mutation is important, you have to understand the functional repercussion. So here in this case, they found, again, like in other epilepsies, gain of functions and loss of functions. So this is the channel on the left side, and you see where all the patients are with their mutation, and then below that you see the functional repercussion of that mutation. And some of these children had like a gain of function, like the V478M. And there, because they know that this is a gain of function, they tried all sorts of drugs to reduce this gain of function as a potential treatment for these children. And actually fluoxetine was in the gain of function variants actually very effective. No big data, it's not like hundreds of patients are being treated, but you feel that you have this mutation in KCNA3, it's a gain of function, and perhaps you should try not carbamazepine or something else, but really fluoxetine, which is more precision medicine for this epilepsy. Another example, a little bit different, but this is the NMDA receptor. NMDA receptor is an excitatory receptor with glutamate as a neurotransmitter. It's a very complex receptor, and actually the receptor itself is built by several units as usual, and these units are coded by GRIN genes, GRIN1, GRIN2, GRIN3, and GRIN4. So you need normal GRIN genes to have a normal NMDA receptor. And we know the clinical picture of these epilepsies, GRIN2A, GRIN1, GRIN2B, GRIN2D. Most of these children have epilepsy. GRIN2A is associated, as you know, with, for instance, Landau-Kleffner syndrome. And you see the variety again. Some of these children have an intellectual disability, some of these children are quite normal, early onset, and some of the children late onset. But again, a very big variety. Now, understanding the mutation again, they found that there are gain of functions and loss of functions again. So this is the same story. Now, what they did is they actually found like 24 patients. They included this in this study, 24 patients with a loss of function. So that means that the NMDA receptor would not work because of this loss of function. Now, the way to change that was, for instance, to give serine. And serine is a small molecule, and if you give that drug, you can hope, as you can see in the lower right with serine, that you will activate again this receptor. So instead of a loss of function, you make it normal again. So this is a nice study, a very influential study for the patients, although the results are not really exciting, but it's conceptual a very nice study because it was a long-term study, 52 weeks, and the primary outcome was developmental outcome, because this is again a severe epilepsy in most cases. So if you find a drug like serine, perhaps it will change also the developmental outcome. Secondary outcome measures were EEG and clinical or seizure frequency, but the primary one was developmental outcome. And they could nicely show, although the differences, as you can see with me, blue versus red, are not really big, but they could nicely show that with this long-term treatment with serine and a loss of function of brain patients, you see that they are doing much better in adaptive behavior, motor function, and quality of life. Again, I'm not overly impressed with the results, but it's a nice way to try to really focus on the pathophysiology of these mutations, give this very focused precision drug, serine, which is a normal small molecule, and you see that it might change the outcome of these patients. Now, by the way, if they looked at epilepsy, some of these patients had very severe EEG, and with the serine, EEG was, in some of them, not in all of them, was completely normal after this treatment. So let's move to the last and the most exciting part of precision medicine. I do think, and I do believe, and I know the data, that in the very near future we will be able to treat many of our genetic epilepsies with genetic treatments. And genetic treatments can be done at different levels. Now, there are a couple of, actually not a couple of, but there are many challenges if we think about genetic treatments. And on the right side, you can see with me the different possibilities. I mean, playing with the genes, I mean, it's not only gene replacement. You can work with antisense oligonucleotides or other RNA therapeutics. You can do gene replacement, you can do genome editing, epigenome editing, nonsense mutations, regulatory elements in engineering, all very difficult to understand for the clinician, but this will be part of our life in the next years if we want to understand these genetic treatments. Nowadays we use, if you look at delivery platforms, like what sort of genetic platform do we need to introduce it into the patients? Mainly it's viral with AAV and lentivirus, but that's the techniques. It's important to understand it. But on the other side, in blue on the left side, you also see other challenges. Because how to do a trial with genetic treatment? Can you actually ethically have like number of punches every 3 months and placebo? So can you still do the classical placebo-controlled trials? I know in neuromuscular diseases it has been done, but there are ethical concerns about these genetic treatments. We also have to understand very well the natural history of these diseases. Safety is a main issue, of course, because we are actually changing the gene expressions in these patients. We have to know also, do we want to target all brain cells, or a couple of brain cells, or only the hippocampus, or only the GABA interneurons, for instance? So there are many things, challenges to be considered when we start with these genetic treatments. But this is happening right now, and we have sort of answers to most of these questions. And the results of the first trial are already there. So what we can do, and this is an overview from a very nice paper published this year, we can work at the DNA level, and we can work at the M-messenger RNA level, so at the transcription and the translation level. Now, if you start with DNA, on the right side you see all sorts of possibilities, but in light blue is what is happening already right now. And the most advanced trial is the one with ADX at that level. I mean, this is a clinical trial starting, or having started a couple of months ago. So this is actually providing, and I will show you some details about this, providing a new gene, because you want to overrule the mutated gene, and you will introduce a new gene that will be effective. At the lower level, in the messenger RNA, you can play with antisense oligonucleotides. And again, there are many possibilities, but also difficulties. But here, we really have nice data already now in the STK1101 study in Dravet syndrome. This is with ASOs in Dravet syndrome, and these results are amazing. And I can tell you that probably by the end of this year, the FDA will approve this treatment already for Dravet syndrome. So it will take another couple of years in other countries, but this is a clinical reality. So it's better to understand what is really happening. Now, Um, if you look at this ASO treatment possibility, and this is from the company Stoke, so the STX-001 trial, in normal situations, and if you look at the left side, in normal situations, before you get sodium channels in blue below, you really have to splice out in light blue this exon, the NMD exon. You have to splice it out. If you do this, you will have productive mRNA, and then you will produce sodium channels. Now, in Dravet syndrome, one allele out of the two is deficient, so it's a haploid insufficiency. So this thing is really not happening in 50% of the cells. So what this technology is doing is actually it gives you an ASO, and with this ASO in red on the right side, you splice out this exon, so to increase the possibilities of producing sodium channel. And that really works, because the very first results of the largest study was published. No details about this poster. This was presented last year at the American Epilepsy Society, and I will focus a little bit on the main outcome. And here on the left, upper left, you see the seizure frequency decrease. Now, this company had needed like 2 or 3 years to find out what is the real dose, the effective dose to give, and how long and how often should you give this. This is given by lumbar puncture every 3 to 6 months, and the effective dose is 70 milligrams, and at least 3 times. But if you look at the results, 3 months and 6 months, you can see with me that the large majority of the patients have a seizure frequency decrease of more than 50%. But it's actually much more subtle, because if you look at the dark green, these are patients that had at least 3 times 70 milligrams, and their seizure frequency is in most of them reaching like 80 or 90%. So this is amazing. We cannot have this level of efficacy with the drugs at this moment. But much more important is that when we give this treatment, we also see a profound effect on comorbidities. And for the parents with the child with Dravet syndrome, this is much more important than seizures. I'm exaggerating a little bit, but it's really important. So some of these children, after the treatment with this genetic treatment, started to talk. I mean, they were like 5, 6, 12 years old, had really speech and language problems, but with this treatment, the language and communication started again. I'm not saying they're becoming normal, but they started again. They are very much better in motor function after these treatments. I mean, they had less severe seizures, but also better concentration, better cognition. No exaggeration, but these effect sizes are much larger than we see with the best drugs at this moment, with CBD, cannabis, or with fenfluramine, for instance, in Dravet syndrome. So I think this will become really a clinical reality in a couple of years. And the other trial that I was talking about, it's called ATX-101. This is even more fantastic if you look at the scientific side of the whole thing. So this is a one-time injection intraventricular with AAV vector, and you inject like a combination of things. You have a regulatory element and you have a transcriptor element, and the regulatory element in blue is actually making that this AAV vector is only reaching GABA interneurons, which is fantastic. That's what we want in Dravet syndrome. And the green one is actually changing the expression of sodium channels. So number 4 at the end, you will see that because of this AAV vector and transcription increase, you will see more and more sodium channels. We don't have final results yet, far from final results, but this trial is going on. The main advantage might be that this is a single injection. And now if I talk to parents with children with Dravet syndrome, most of them still prefer the Stoke, like every 3 months an injection. And it's a bit of a surprise, because every 3 months you have to do a lumbar puncture, or every 6 months, but still you have to repeat it. but for the parents it's like it's more controllable. I mean, you can stop the treatment with the AAV vector. In their perception, it's a one-time shot. You're changing the DNA. That's how they think about this, and we are not sure yet about the efficacy and the safety. But I think this will be safe, and I think this will work. And again, this is just two examples. There are not too many more, but the methodology is there, and for many genetic epilepsies, also for Angelman and Rett syndrome, we will see trials in the very near future to try to change the phenotype of these children. So I thank you for your attention. I hope I have given you an overview of what is currently happening with precision medicine. These are exciting times. I think you will see a change in treatment paradigms for many of the epilepsies. Thank you very much.
هو دكتور ليفن فيرتشوال مش موجود. اوكي. Thank you, Professor Levin, and now we will shift to the second speaker.
صباح الخير عليكم جميعا. إن شاء الله هنقدم النكست سبيكر للأستاذة الدكتورة نهى ثروت، بروفيسور في بيدياتريك نيورولوجي منصورة يونيفرسيتي. دكتورة نهى من الناس الدقيقة جدا والجادة جدا في شغلها، وبصراحة أفادت وحدة البيدياتريك نيورولوجي في المنصورة جدا، وإن شاء الله التوك بتاعها هيكون ممتع. بتقدم بخالص الشكر للدكتورة مريان يسري